It is a true pleasure to introduce a colleague and a friend, Dr. Hassan Chami. Dr. Chami is a graduate of the American University of Beirut and did his training at Boston University and is boarded in the fields of pulmonary medicine, critical care medicine, and sleep medicine. Dr. Chami is currently an assistant professor of clinical medicine at the American University of Beirut, and he will be discussing with us pulmonary rehabilitation, the evidence behind it in COPD patients. Dr. Chami.
Thank you. I'd like to start by thanking the organizing committee for inviting me to give this presentation on the rationale and evidence of pulmonary rehabilitation in COPD. This is the outline that I'm going to follow throughout this presentation. We'll start by reviewing the mechanism and management of dyspnea and exercise limitation in COPD. Then we'll talk about the structure, the goals and benefit of pulmonary rehabilitation. Then we'll move to discuss patient selection, so who to include in such programs. And at the end, we'll touch on the initial components of pulmonary rehabilitation, including the initial assessment, the exercise component, and the educational component, which will be elaborated more upon in the coming lectures. So patients with COPD suffer from symptoms of cough, breathlessness, and exercise limitation, which together with frequent exacerbation and hospitalization would lead to poor quality of life. Cardiopulmonary dysfunction is the most important cause of dyspnea and exercise limitation in these patients. However, there's growing appreciation of non-respiratory factors that may be contributing, such as deconditioning and skeletal muscle dysfunction. So patients with COPD would start by experiencing dyspnea because of cardiopulmonary limitation, and then they would try to avoid this unpleasant feeling by reducing their exercise, which leads to inactivity and deconditioning. So they will assume a sedentary lifestyle which feeds into their dyspnea, and they go into a vicious cycle of increasing deconditioning and dyspnea and further reduction in exercise endurance. In addition to this deconditioning, the patient with COPD also have skeletal muscle dysfunction. This has been proven in few studies, and it's characterized by reduced mass and strength. So both mass and strength are reduced. Of course, deconditioning would contribute to that. However, there's other factors. Importantly, systemic inflammation has been shown to be more prominent in patients with COPD and negatively affect muscle function and mass. Oxidative stress, hypoxia has a negative effect on muscle function and mass. Malnutrition, which may be prevalent in severe COPD. The use of corticosteroids appropriately during exacerbation or inappropriately for maintenance can also have a negative impact on skeletal muscle dysfunction. And a subset of patients, especially elderly, will have anabolic hormone deficiency. So what we know about management of COPD, primarily dyspnea and exercise limitation, we use steroids, bronchodilators, and oxygen. These are the traditional pharmacologic therapy that address cardiopulmonary limitation. However, pulmonary rehabilitation would address deconditioning and skeletal muscle dysfunction. So we'll move now to talk more about pulmonary rehabilitation. According to the ATS ERS statement, the last one in 2006, we're expecting one to come out soon, maybe next month in the ATS meeting. Pulmonary rehab is defined as an evidence-based, multidisciplinary, and comprehensive intervention for patients with chronic respiratory disease who are symptomatic and have decreased daily life activities. This is a very broad definition, and the main component of a pulmonary rehab program are exercise training and education. However, psychological counseling may be also helpful, especially that anxiety and depression are prevalent in patients with COPD, up to 30%. And nutritional counseling is also helpful for patients who are overweight or nutritionally deplete. Smoking cessation is also a must for patients who continue smoking. So through this multidisciplinary approach, pulmonary rehabilitation does not only address this vicious spiral of increased inactivity and deconditioning, but also impact muscle wasting, weight loss, altered mood, and relative social isolation important factors that affect patient quality of life. The goals of pulmonary rehabilitation in patients with pulmonary disease in general and COPD are to reduce symptoms, optimize functional status, improve quality of life, very important, that's what the patient cares about, increase participation in everyday activity, and all that while reducing healthcare costs. Who in the room thinks that pulmonary rehabilitation can achieve all those? Can I show a hand? Do you believe that pulmonary rehabilitation can do all those? Well, the minority that raised their hand, you're right, there's excellent and mounting evidence, level A we're talking, so randomized controlled trial and meta-analysis that shows that pulmonary rehabilitation improves exercise capacity, reduces perceived intensity of breathlessness, they also improves health-related quality of life, and reduce anxiety and depression associated with COPD. In fact, when pulmonary rehabilitation is compared with the same number of psychotherapy session head-to-head, pulmonary rehabilitation is superior at improving anxiety and depression in patients with COPD. Same number of sessions, psychotherapy, pulmonary rehabilitation, patients have less anxiety and depression at the end. And finally, very important, and what makes pulmonary rehabilitation cost-effective, it's been shown to reduce the number of hospitalization and days in the hospital in patients who have previously exacerbation. So we'll review a bit of this evidence in a bit of detail because it's very important. So this is the Cochrane database review, a meta-analysis of 16 randomized controlled trial that includes 669 patients. And it showed statistically and clinically significant improvement in functional exercise capacity as measured by the 6-minute walk test. Patients were on average able to walk 48 meters longer. What's thought to be clinically important is about 35 in most studies, and some quote 50. So both statistically and clinically important. There's also studies, similar meta-analysis that show and improve not only in the amount of work that they can do, the length and the distance, but they can also, the peak intensity is also improved by about 8 watts, which is also considered clinically relevant. Similar meta-analysis also show improvement in health-related quality of life. This is, same thing, meta-analysis of 6 studies that looked at the St. George questionnaire, and there's an improvement, statistical and clinically meaningful in their perceived health-related quality of life. Similar studies also in a Cochrane database in the same review that shows an improvement in quality of life as measured by the chronic respiratory disease questionnaire. And here also the improvement is statistically and clinically meaningful. The cut point is usually 0.5 for a meaningful improvement on this 7-point scale, and the improvement on average is 1. And also this is for the dyspnea dimension. There's 4 dimensions to this questionnaire. They're all improved in patients who undergo pulmonary rehabilitation. So the patient is able to walk more, the patient feels better, and how about hospitalization? This is the evidence comes from this and several other studies. This is a randomized controlled trial of 191 patients. These patients had exacerbation before within the last year, and patients who were randomized for pulmonary rehabilitation had less hospitalization over a follow-up of 1 year, 12 months, and it was statistically significant. They spent less hospital days, so they spent less time in the hospital. They were hospitalized less, the frequency is less, and the amount of time spent in the hospital is less. A very powerful study. The number needed to treat was 5.5 patients, so you need to enroll 5.5 patients in pulmonary rehab to prevent 1 admission. Okay, so that's what makes it really cost-effective. The same study shows that a more general reduction in healthcare utilization. We see that patients who were enrolled in pulmonary rehab had less ER visit for exacerbation, and the difference was statistically significant. They also had less number of unscheduled visits for family practitioners, so less utilization of healthcare resources. How about after exacerbation? So we get this patient that comes to the hospital. When is a good time to enroll the patient in rehabilitation? Is it safe? So a few studies looked at that and found that if you actually enroll patients within a month after admission for exacerbation, the results are even more pronounced in everything that I mentioned before, and this is also a meta-analysis for readmission. And we have here 5 randomized controlled trial lumped in a meta-analysis, 250 patient, and we see a really sizable effect size in reduction in hospitalization in this patient, and we will see also that mortality is less, so it's not really it doesn't have a bad effect on patient who had recent exacerbation. So that's really what makes pulmonary rehabilitation cost effective. You save on the cost of admission. You're paying more for the rehab program, but you are saving in the long run for readmission, ER visits, and health care utilization. So in addition to this level A evidence, very convincing evidence, there's suggestive evidence, what's level B, that pulmonary rehab actually improves survival. Can you believe that? There's so many studies that looked at inhaled steroid, long-acting beta-agonist, everything is questionable, p-values of 0.51, and now we have suggestive evidence that we have an intervention that actually may improve survival in patients with COPD, in addition to oxygen replacement. So this is a meta-analysis here also from a Cochrane review that shows a sizable decrease in mortality in patients with COPD who undergo pulmonary rehabilitation after exacerbation. Now, why is that, despite the sizable effect, why is not level A? The issue is small sample size, so there may be a risk of bias. So that's why it's suggestive, not conclusive evidence. There's also suggestive evidence that pulmonary rehabilitation actually speeds recovery after hospitalization and exacerbation, enhances the effect of bronchodilators, so it's an additive effect on top of pharmacologic treatment, and that the benefit extend well beyond the period of training. So usually you would enroll the patient for 2-3 months, and the beneficial effect persists. So who would you enroll in these programs? It seems that all COPD patients appear to benefit. However, the benefit has been most primarily documented in patients with significant dyspnea, as measured by the MMRC questionnaire more than once. So anyone who cannot keep up with their peers on a flat surface, or who has to stop to take a breath that would put them in an MMRC grade 2, they would benefit. And after exacerbation, we saw that the benefit is substantial. So according to the new GOLD classification of group, it seems that patient in group C and D, so these are the patients at increased risk of exacerbation as measured by previous exacerbation history or severe spirometric impairment, has a beneficial effect from pulmonary rehab, as well as patients who are symptomatic, so patients with MMRC more than 1, 2 or more, B, so B, C, or D. And the weight of the evidence is so convincing that the most recent GOLD guidelines actually consider pulmonary rehabilitation as an essential intervention for patient group B and C and D, for these same groups. So they consider pulmonary rehabilitation as essential in addition to smoking cessation. Other indications beside what the guidelines say, specific patient that may benefit, the patient who have decreased functional status, decreased occupational performance, difficulty performing activity of daily living, psychological problems related to COPD, nutritional depletion, and increased use of medical resources may benefit. Now, who not to include? Who should be excluded from this program? It's basically anyone who has unstable cardiac disease. So a patient who has a recent MI, unstable angina, you don't want to have them exercise. Most patients actually will gonna need cardiology clearance before they are enrolled. Patients with critical aortic stenosis, there's also dangerous for them to exercise. Recent pulmonary embolism, you don't want them in your program. And there's also a category of patients who are so impaired that they're bed-bound. And these patients can exercise safely, but they're unlikely to benefit. So patients who are bed-bound because of severe dyspnea or musculoskeletal impairment are unlikely to benefit and should probably not be enrolled in these programs. Now, interestingly, active smoking is not a contraindication. Patients will still benefit, but these patients have a higher dropout rate. Now we'll move to discuss a bit the components of pulmonary rehabilitation. The most important and the cornerstone is actually the initial assessment, and it identifies unique problems of the patient including gait disturbance, nutritional depletion, and depression. So it's used to tailor intervention and bring in additional resources to the basic components, so we can get in psych consult, nutritional evaluation, or smoking cessation for patients who continue to smoke. The initial assessment is actually very detailed. It includes medical history, physical exam. There should be diagnostic tests. You should review the spirometry to make sure the patient fits the diagnosis. EKG should be done. And then a detailed assessment following specific questionnaires that review the patient's exact symptoms, the activity of daily living, nutrition, educational background, what they know already about the disease, and a psychological assessment. It's also very important to measure the exercise capacity at baseline and at the end of the test, of the pulmonary rehab program. So we use a 6-minute walk test or shuttle walk test to estimate the distance that they can move, and based on that distance, we can estimate their exercise capacity in watts, and we would tailor the intensity of the physical rehab intervention based on this exercise capacity. We can also do a CPAT, a formal cardiopulmonary exercise test, to actually measure VO2 max, the exercise capacity, and tailor the intensity of the program. All programs basically do one of those three and repeat it at the end to measure the improvement. And at the end, there should be a careful musculoskeletal assessment for exercise. Most of these patients are elderly. They may have osteoporosis. They may have difficulty ambulating. You have to make sure that it's safe for these patients to exercise. So you have to know their limitation and tailor some of the intervention to these patients. So some patients may not be able to climb stairs. Some patients may need to just do bikes and so forth. When this initial assessment ends, there's the goal formulation. So patients would sit with the coordinator of the program and they set their goal. The goals have to be measurable, they have to be patient-specific and realistic. And examples should be like the patient may want to be able to play with grandchildren or walk farther. They maybe just want to be able to take a shower without feeling suffocating, or able to clean their house, or even return to work. So all of these will have to be really set ahead of time. So like I said before, the exercise training is really the main component of pulmonary rehabilitation together with education, so we'll talk a bit about it. The exercise training not only helps the patient cope with the sensation of breathlessness. It was thought initially that all we're doing is we just teach the patient to accept their dyspnea by just getting used to it. Actually, there have been studies that looked at peak oxygen consumption, peak workload, endurance time, and they're all improved in patients who undergo physical exercise training, which suggests that it actually improve muscle function and cardiopulmonary function. It's not just getting used to the idea of feeling dyspneic and keep going. The recommended number of exercise session is 20. At least, and the frequency, the recommended is 3 times per week. It's okay to do 2 + 1 at home. That's what we actually adopted in our program at AUB because of transportation problems, and really it's impractical for patients to come 3 times to the program. The length of program, the recommended is 6 to 12, although the longer program have shown to confer more prolonged and added benefit. The session duration is anywhere between 20 to 45 minutes, and the intensity of exercise, I remember I told you we measured the VO2 max, or we tried to estimate it based on the 6-minute walk test initially, and then we would dial in and give an exercise prescription of 50 to 100% of the VO2 max. Usually high intensity is preferred, but patients who cannot tolerate that would still benefit with low exercise intensity. The modes of exercise, initially there was a focus on only endurance training, but then the evidence showed that adding strength training, so weightlifting and elastic bands, TheraBands, would actually confer additional benefit. And the exercising both lower and upper extremity are beneficial. So we basically do a combination of both upper exercise, lower exercise, endurance, and strength training every time the patient comes. 2 words about respiratory muscle training. Although it's appealing, you would think that the diaphragm suffers in patients with COPD and you want to train it. It's not really recommended. It's not been shown to add benefit on top of endurance and skeletal muscle training. Although it's been shown to increase muscle strength and endurance for the diaphragm and respiratory muscle, the effect on exercise tolerance and quality of life is not proven, so it's okay to include it, but it's not really recommended. Oxygen therapy during physical rehabilitation is of paramount importance. It's very important to measure their oxygenation during exercise. Measuring the oxygenation at rest will not predict what's going to happen during exercise. And so it's very important to maintain an oxygen saturation above 89% and to supplement with oxygen to improve exercise tolerance. Bronchodilators also very important. As we said, it's an add-on effect to the bronchodilators, so it's very important to optimize home therapy before the patients are enrolled, and it's very important to have bronchodilator available on premises to give if the patient develops wheezing or even prior to initiation of exercise. It's very also important to have a crash card in the rehab program in case problems arise. So very important to have oxygen, nebulizer, and ability to perform ACLS if the patient is in trouble. I'm just going to mention 2 words about the educational component. It's going to be covered more details in a later talk, but it's also an essential component of pulmonary rehabilitation. The sessions are to be coupled with exercise training. So the patient comes, they go through an educational session, then an exercise training session. And the education component is not really just a didactic. The patient don't sit there and listen to a talk, although some information is important because it improves their communication with their care provider. It's the main education component is skill-oriented and also focus on self-monitoring and give the patient an action plan. This will be talked about in more details in a subsequent talk. I'm going to skip through those as they're going to be covered. And I'm just going to end by saying and reiterating an ATS statement on the integrated care of COPD patients, that focusing therapy solely on reversing airway obstruction is now considered suboptimal care and will produce suboptimal outcome. I thank you for your attention.
Thank you, Dr. Chami. We are a bit pressed for time. I will open the grounds for 1 or 2 short questions. Any questions? Yes, please.
Yes, go ahead.
Thank you very much. شكرا جزيلا على هذه المحاضرة القيمة. معلش أتكلم بالعربي؟
تفضل.
نحن عرب ونتكلم بلغتنا العربية.
ما بيصير.
الواقع أنا بدي أتكلم عن الأردن. بالأردن في عندنا 5 ملايين بشر. هال5 ملايين 2.5 مليون بدخنوا. 2.5 مليون في عندك 250,000 is going to have COPD.
Yes.
معناتها بدك ميزانية الشرق الأوسط كلها لتعالجهم على الجولز تبعك. نيوتريشن واكسرسايز و6 minutes walking وECG PFT. فليش ما نكون واقعيين جدا جدا ونعمل حملة شرسة جدا على التدخين وبالتالي ننقذ الأمة العربية من هالوباء القاتل.
أنا
ملاحظة
موافق معك 100%. بس في ناس اوريدي عندهم المرض مش رح تتركهم.
هيدي نحن بنشتغل عليهم اصلا. نحن كيف بدنا نعيش اذا ما في COPD؟
بس I'll give you what to do.
خليهم موجودين الله يرضى عليك ويدخنوا وبالليل يأرجلوا مش اشكال يعني. بالنهار يدخنوا بالليل يأرجلوا. فانا بدنا شغلات براكتيكال الله يخليك. شغلات نتحملها مو شغلات نتخيلها. يعني بدنا شيء واقعي لهال4 مليون في الأردن اللي عم بيدخنوا واللي معهم COPD واللي أكلين هواء فاينانشالي وسوشيالي وميديكالي واتسترا. شكرا جزيلا.
أنا بدي أتشك حسن معلش بس تعقيبا على اللي قاله الحكيم. إذا فهمت مظبوط if I got it right ال pulmonary rehabilitation especially if it's tailored إذا معمولة على قياس المريض المنفعة تبعيتها أكبر من معظم الفارماكولوجي اللي نحن عم نعطيها واللي عم بتكلفنا بلوي. فأنا بتصور إنه الحملة اللي بدك تعملها للدخان واللي هي تكون مشكورة بينعمل معها حملة بنفس القوة للpulmonary rehabilitation لأنه برأيي المنفعة بتكون للميلتين المريض اللي أوريدي صار عنده المرض واللي فينا نمنعه يصير عنده المرض. هون بس أنا بدي يمكن اسمح لحالي بسؤال بسيط هذا يمكن حيبين بعد شوي بالlectures بس is it covered? Insurances, do they cover this service? And if not, how much does it cost?
The hopeful answer is not yet.
So not yet.
we're actually working with insurance companies to convince them of how cost effective this intervention is in order for them to cover it. And it's still up in the air. We haven't heard back from them. So that's one limitation. But I totally agree. رح ارجع احكي بالعربي. الكنديان هن عاملين اكثر شيء ستاديز على البولمونري ريهاب، 3/4 هدول الميتا اناليسيس كلهم من كندا. They actually compared hospital-based outpatient, يلي this is the gold standard هلا, to home care. So you don't actually have to enroll patient in an outpatient hospital-based setting. What you can do is have an expert and specialist give them an exercise prescription and follow up on them while they're at home, okay? And even walking, you don't have to go very sophisticated, and you will have some benefit. But it's still important to have a center of excellence where you would have a formal pulmonary rehabilitation program so that you get the expertise for those who can afford it, and then build also a community-based and home-based that's less expensive. So تعمل البروجرام المضبوط حتى يصير في الاكسبرتس وبتعلم الناس يعملوه ببيتهم والكوميونيتيز. هيدا الكندي اللي عم بيعملوه and it's been shown head to head انه home based is at least as good to hospital based outpatient.
Thank you very much. I guess